Okay, good afternoon, everyone, and thanks for joining. I have a lot of information that I will try to impart to you about what we're doing in the emergency department. And if you have burning questions, you can put them in the chat and I will try to look at those as we go through because I don't want to continue on if you have some pertinent questions, but there will be lots of time at the end for you to ask questions. So I think with that, we'll get started. And I'll move my slide. Okay, so first of all, I have no disclosures except for my current funding, which is here. So we know the extent of the problem, and these are the new data results from the National Survey on Drug Use and Health. They always come out in October of the year, and they're always for the year prior. What you might notice here, and I just want to make sure if you look at these every year, is they changed how they collect some of this data using the DSM-5 criteria so that these numbers can be very off of what you've seen previously. So you have to take this with a grain of salt if you're always looking at these results every single year. There are 18.4 million Americans age 12 or older that had an illicit drug use disorder in the past year. 2.7 million had an opiate use disorder in the past year, and 9.5 million report misuse of opioids in the past year. And that percent was the highest in the young adults 18 to 25 range. And as you may have seen, this article came out not that long ago in April in JAMA. Unfortunately, that overdose mortality has greatly increased in adolescents, as much as 95% from 19 to 20, and then from 20 to 21 up by 20%. And you can see that it's driven primarily by fentanyl and its synthetics. And the young adolescents are often buying pills over the internet or from some people, and those pills look exactly like a prescription pill with the same numbers on it, etc. And they are all fake and they are fentanyl, so that the massive amounts of overdose are happening because of that. Overall, you've probably seen this slide quite a bunch, but this is the updated data that as of 11/21, over 106,000, almost 107,000 overdose deaths from all drugs have occurred. And obviously that's driven primarily by fentanyl, which went up 24% from the year before. So now that is over 70,000 individuals. I always show this slide because I think it's really important that besides the data that we look at people, and these are individuals, and they are people's, children, their husbands, their wives, their sisters, their brothers, their whatever, and their best friends, and that these individuals are dying often who are quite young. If you look at the overdose rate as it is now, we have 293 people that are lost every single day by an overdose. And again, almost 2/3 of those are related to opioids. We also know that treatment works, and I don't have anything to do with this. These are studies that have gone on for years that have shown that methadone and buprenorphine, particularly opiate agonists, are very effective in treating opiate use disorder, in reducing its use and in retention and treatment. And we also know that the present evidence does not support the fact that you have to have psychosocial interventions to make retention and treatment happen. We know that if we can keep people in opiate agonist treatment, we will reduce those illicit substance use. There will be less viral hepatitis, HIV, and IV injection drug use complications. We know that there will be a reduction, obviously, in overdoses and deaths, in risky behaviors, in legal consequences, and thus people would have more time to have sustainable relationships, gainful employment, and deal with other medical problems that they may have as a result of their drug use. The National Academy of Medicine in 2017 came out with their recommendations, and they were pretty much here, know that what we know, they say these medicines save lives, they're associated with improved outcomes, There is absolutely no evidence that we have to withhold MOUD because of the availability of behavioral interventions, that most people who could benefit from these medications don't receive them. And we clearly know time and time again that access is inequitable. It is inequitable for large portions of individuals based on their racial and ethnicity, and also in vulnerable populations just due to their socioeconomic groups. Withholding or failing to have availability of all classes of MOUD in any care of the justice system is really denying treatment. And we also know that if we don't look at these barriers and use these medications, that we cannot address the opiate crisis without it. So here we are today. We also know that the emergency department offers a 24/7, 365-day option to combat the opiate crisis. And why focus on us in the ED? And that's clearly because that's where the patients are. More and more today, you will see that primary care access is incredibly limited. We know this. The EDs are overrun. Currently, we've had the worst crowding that we have ever had in the history of emergency medicine right now. And that is not due to COVID. That is due to the fact that people cannot get that still people are not letting people into primary care, that they have to be some kind of telemedicine visits, which of course many people don't have access to. So even more than ever, this is where everyone can show up. Every year the drug-related ED visits climb, and I don't see an out to this. What we see when patients come in, and again, I'm really try to minimize the word screening, because when you say that word, people get very crazy, because in the emergency department, for example, there are probably over 60 to 70 things we are supposed to screen for in every patient. It's overwhelming. So everybody starts fighting about whose job it is. Is it an epic? Is it the nurse? It's this. Whose job is it? I don't want to do it. So instead I say, look, this is a problem that's hitting us right in the face. So let's look clearly and just see who we can identify right away. Even if we just start there, that's a great place. So people come in with overdose. There you go. It's right tattooed. They have an overdose. So you can go to them. People come in seeking treatment more so than either treatment because they want to be in treatment, or they're seeking it because they're in withdrawal, whatever for their withdrawal symptoms, that's obvious. And then there are people we find out when we just do our normal history and physical that there is a problem with opiate use disorder, and then we can work further on that. But just seeing those people that will pop up on Epic or Cerner is a good place to start. We know that COVID-19 really collided with this epidemic and made it worse. Over the left-hand side, you can see a March 2020 where our ED visits then really went down, but the other mental health conditions, including substance use disorder, went sky high, and that has continued till today. And so on the right-hand side, it really showed you that the gray was the total visits. They were decreasing, but our opiate overdoses and all overdoses were massively increasing. And they are, to this day, just going up and up. And pretty much what we see every day are mental health conditions and substance use disorder. We know the consequences of inaction, and this is indebted to Mark LaRochelle, who published this a while ago now in 2018. Which looked in Massachusetts at all of the patients who had non-fatal overdose in a past year. And here he looked at these. You can see there were over 17,000 patients with those years. And so you can imagine this is much worse even now. And he's repeating it, I believe, now. But what he found was that at the end of those 12 months, having had an ED visit for a non-fatal overdose, that the all-cause mortality was close to 5%. Now, to give you some context of that, there isn't anything else that's close to that except an acute ST elevation MI. So nothing that I see in the ED would account that I would expect that almost 5% would be dead in a year if I don't do something. So that gives you some idea of how important it is. We also found out that at that time, and it's really not much different with people who have presented some recent papers, that only 30% of people in that after that event were placed on medications. And then here you can see that if they were placed on buprenorphine or methadone, they had a substantial reduction, more than 50% in mortality. But if they were placed in naltrexone, that did not occur. So we obviously advocate for any opiate agonist for our patients. We also know the evidence, this was our original paper in 2015 that showed that if we could get people on buprenorphine, that they were engaged in treatment more than twice as much as anyone else. So they were almost 80%. What we looked at before was not really what happens in an ED, because we wouldn't do that where we were at Yale, because we were always doing something. So we actually always did this middle group, which is we have health promotion advocates who would see patients. They would do a brief intervention and they would refer them with a facilitated referral, meaning they would call the place, they would tell them they were coming over, depending on the place, they'd fax them or whatever. And the patient was expected to show up. And that actually did decently. I thought actually that would be the best thing when I started this. And then referral again was not a plain referral. We actually, based on the patient's preference and their insurance status, we gave them exactly where they could go in the city. So again, that was much more than is usually done for care, but we were surprised at how much the buprenorphine initiation really got people to stay in treatment at 30 days. We also noted that their past 7-day use of opiates was substantially less than the other two groups when they were placed on buprenorphine. And then Dr. Bush here in the School of Public Health did a cost-effective analysis of that treatment initiation and really found, she did these cost effectiveness acceptability curves that you see there on the right side for treatment and change in opiate-free days. And for any amount of treatment, buprenorphine was always, any willingness to pay buprenorphine was always much cost effective than the other treatments. And for every 1 day free of opiate use, again, there was a better use of willingness to pay even $1. So therefore, we know it was cost effective. Regardless of all this, we know that we aren't doing as good of a job as we could. And this was a little bit old, but unfortunately, it's hard to get this data recently. So although we have prescribed more buprenorphine in the ED over time, it's nowhere near where we need to be. And as you can see here, this is when the article was published in 2015. So we have escalated, and I'm sure it is higher now, but you can see we have a long place. We have a long way to go. So how can we do it? As I said, we want to identify patients. We want to provide treatment, which means that we want to initiate buprenorphine when appropriate. And we want to give and provide overdose education and naloxone distribution. Obviously, the best thing to do is to hand an naloxone and an actual naloxone kit to the patient. If not, you can write a script, but I could tell you that rarely will those scripts be filled. But we're lucky here in our state that they do provide it for us, and we do hand that out to a family member, to a friend, to the patient, whatever. And then we directly link them to a program and all the preventative services that they may need, like whether it is needle exchange programs, et cetera, housing, whatever, we send that out. So then when we did this study, we said, okay, now we know this. The latest research says that we really should do something about all this. So then we received another grant that I can tell you just finished, but opiate use disorder in the ED project, ED Health, which really was an implementation project. It was a hybrid type 3 implementation effectiveness study, which means that it accentuates implementation over effectiveness. And we looked at the practice of 4 geographically diverse urban academic emergency departments, and we test some strategies around effectiveness as well, but our primary goal was implementation. This was a large project in 4 sites and a large team of people who worked on that. And the places where we did it was both at Johns Hopkins and Mount Sinai in New York, University of Cincinnati, and in Seattle, the University of Washington. And then we had a huge Yale team that also helped with this. what we did was we really looked at different populations. One were the clinicians and the others obviously are the patients. So with the clinicians, we did focus groups and surveys of really all ED clinicians and staff. And we also did interviews with patients with OUD. We also interviewed clinicians at opiate treatment programs or other referral sites. And then we collected a bunch of data directly from the EHR. How much Bup was given over that period of time, how much naloxone was distributed, et cetera. And then we looked at how much X-waiver training had gone into place pre and post. We looked at patient observation cohorts. We had planned on a sample size of 960, 120 in each site pre and post. And the pre was prior to us doing all of our implementation strategies, which I'll tell you about. And then 12 months post. COVID sort of interfered with this and some other things. So we got a sample size of 756. Our implementation facilitation, which was what we were really looking at to see if this worked better than if I gave a traditional grand round speech. The implementation facilitation is really a combination or a series of events that we do. And we were the external facilitators. We helped them with formative evaluations from all of our surveys. We got local champions involved and stakeholder engagement in the community. We did, we helped them to tailor their program. They did it, but we helped them to their site specific. We provided education, academic detailing to every doctor, or every nurse, or anyone we could find willing to do it. We talked with them about performance monitoring and feedback. We started learning collaboratives that the different emergency department and all of the people surrounding that, pharmacists, et cetera, could join once they were in the implementation facilitation activities. We promoted problem solving, and we did some program marketing by giving them out pens and, you know, also some pins so that anyone would say, what's that for? And save lives, use Bup. So this was our timeline and how it worked out. We started in 2017 and went through almost the very end of the year of 2020. And those red dots are the fact that I went to each of these places and gave the same grand rounds, which is your typical 60-minute grand rounds. I would stay extra as long as anyone wanted to talk to me. I would give them any specifics if they asked me for it, but that wasn't included in the grand rounds. It would be a simple thing like I'm doing today. We then looked at patients for 12 months where research assistants went and interviewed patients in those EDs to find people who met the criteria for untreated opiate use disorder. And then we followed them at 30 days and saw whether they were in treatment or not. We continued them with an aggressive 6-month area of implementation facilitation, of which we did all the focus groups, where we gave them all the information we had. We answered every question they wanted. And then we, after that was over, we had another 12-month period where we then enrolled patients with the same thing. The IF activities exceed through that. Once you start the IF, you really continue it through the IF evaluation period. So all of these activities based on what the site wanted happened. We did the learning collaboratives. We did had to pause shortly during COVID because they could not get the RAs into the ED because everything had shut down. We were able to continue more in the last D site, but we could not really do much more in the site C, who wouldn't really let people back in very easily. And as I said, we did all these quantitative surveys and qualitative interviews. And so what did we find? So these are just purely numerical data. There's no statistics on them. So what we did find is we looked, and this was though right from the EHR, that at baseline, there were 259 times ED visits during those 4 sites. And each of those sites saw 60 to 100,000 people. that buprenorphine was administered there or prescribed. And again, that could have been for any reason. It could have been because the patient was already on it and you were just giving it. It could be for any reason. It just counts. And then at the end of the IF evaluation period, during that group, there were 1,256 times that buprenorphine was administered and or prescribed. And the unique clinicians who did that prescribing or administration went from 162 to 449. We also found out that the naloxone being dispensed or prescribed also went up from 535 ED visits to almost 1,100 ED visits at the end. And in terms of those doctors or clinicians that were ex-waivered, there were 10 overall in all the sites that went to 161. So that was kind of cool. And there was one PA that went to 35 APPs at the end. Now, when we look at the outcomes during the patient cohorts, this is what we found. So that in the implementation, these were the percent of patients who received ED bup with referral. And it went literally from 2 patients in the baseline period to 53 patients in the IF period. And so it went from 0.5 to 14.6. And that may seem like, oh, well, it isn't much, but it is quite a feat. We also, during this, patients were untreated, but they could have had methadone in their urine. They could have not been able to want to do it. They could have not wanted to have treatment. So we weren't cherry picking people out by their phenotypes or why or what. Did they want it? Didn't they? Clearly had untreated opioid use disorder, and that's what we were working with. And the effectiveness, which was the percent of people who were engaged in treatment at 30 days, went from 40 in the baseline or 10.2% to 59 in the post-IF period. So that went from 10 to 16%. And again, modest, but statistically significant and important. And how did we define formal? So I'm glad someone asked me that. So formal addiction treatment was anything basically that's paid by insurance, but it was from the, it's not the SAMHSA criteria. It's ASAM criteria, thank you. It's the ASAM criteria for treatment. It could not be a mutual self-help group by any means. It had to be a defined treatment center by ASAM, criteria 1 through 4. And every time that a patient said they were in treatment, they were verified by a call to that treatment center. Patients gave permission for us to verify it by the treatment source, whether it was an ATP or whether it was primary care or whatever. And we called. If we could not verify that the patient was in treatment, then the patient was written as not in treatment. So we didn't do any imputation. So again, that can be why these numbers are wrong. If we couldn't find the patient, or if we did find the patient and they told us something and it was not verified by the treatment center, then they were considered not in treatment. So then what we did was we noticed that if you look on the left-hand side here, that patients in the evaluation period who got bup and who didn't get bup. So we realized that of those people that were in treatment in the baseline, as I said, there were 40 people in treatment, 39 of those did not receive bup and 1 of those had received bup. And then when we looked in the IF evaluation period, the statistician, he noticed that, wow, the difference was 19 people. That doesn't seem like a lot. All of those people had gotten bup. So therefore, we went back and an explanatory analysis said, oh, well, that's interesting. Let's go back and see what bup had to do with in the IF period. We couldn't really look in the baseline period because there's only 1. So there were only 2 people, 1 was in treatment or not. But while we looked in the IF period, we could look. And so we went and looked in that period, what happened if you got bup or you didn't get bup. So if you didn't receive bup, that was 40 out of the 309 were in treatment. And if you did get bup, 19 out of 53 were in treatment. So there is really almost a 3-fold difference. Is if you did get that bup, you were much more likely to be in treatment than if you didn't. So you can see that difference was just all driven by that ED bupe. So we learned other things too. So we did a lot of other, we have published a lot of other papers just in the process of doing this. And this was one of the papers that Dr. Hawk was the first author on. And it looked at barriers to treat and some solutions that were offered during these focus groups. We know that these are barriers. People will constantly say the same thing, like there had to be an X-waiver at the time when we did this trial. There was the 8-hour requirement. They didn't have much experience. We're worried about treatment. However, quite truthfully, when I went to each of these 4 sites, I heard that all the time. I went out, we were there for several days. I went out and found places, and there was places for people to be sent the next day in all of those 4 sites. Wonderful places, 2 of which had the places in their hospital that they could just put something in the EHR and they would call them the next day. It was like amazing. So when people tell me they don't have places to go, I'm sorry, I don't believe them. I'm sure that there's a rare place, but if I go there or find people and do a little digging, I will find places that people can go to. There were competing priorities, of course there are, but if competing priorities, we would say, well, how likely is this person you're seeing today going to be dead in 12 months? Again, you won't see that except for an ST elevation MI, and God knows we have so many criteria that we have to follow every minute that the EKG is done, in 5 minutes that they're up in the kappa by 30 minutes. And most large EDs, maybe they have 10 to 20 a month, when you might have that many per day, or certainly in a couple of days in your ED of opiate overdose or people with any signs or symptoms of opioid disorder. And there was a great misunderstanding and stigma towards patients. So we worked on that. We helped them develop protocols. We did targeted feedback to staff. And I think that's probably the most important thing that I learned here just in general practice is if patients are placed on bupe, and here we have a capacity to ask a nurse for follow-up, or we have our project assertive facing the patient. And then we go back to the nurse and the doctor as much as possible and say, you know, that person you sent, well, they're still in treatment. They're doing very well. And that they only see, ED people only see the horrible things when people come back. So that's a problem. In terms of how much bupe that we gave them in our original trial, you know, we gave them 3 days because we were the first ones doing it. We gave them the bupe, we saw them within 3 days. This was not the case here. They could do whatever they needed to do. I would say the majority of people were given 7-day scripts, but they, you know, that was part of their protocol when they could get someone into a treatment program and when they could not. So depending on that and where they would send the person, we would always encourage people to give them more than what they think, because people with opiate use disorder, you know, are a little disorganized and may not get there that next day, but they might get there in 2 days after. And so always more is better than small amounts. And then we're going to talk about this, about the ASAP recommendations that were very clear to us that really have helped us. There was a question, and I'll answer that quickly too, about take home. In my original study, 50% of people got take homes. And I can't even use that word now, and I shouldn't, but that we have that they are initiating buprenorphine on their own, right? And because many people don't have homes now. So they could get that. We gave them all the information and the patient information to go home and exactly how they take it, unobserved induction. And so that happened too. I can't tell you with each one of these people what they did, but that was part of the protocol with each site. Just to show you another study, this was CTN 79, ED Connect, run by Dr. McCormick and Dr. Hawk. This was in a very, very areas of high need and low resource, and primarily they were in 2 hospitals in New Hampshire and then at Bellevue. And they did it a little bit differently in that they looked at patients and asked them, not only were they eligible to get bupe, so there was a lot going on there, but would they agree to take the bupe? And then once they got that small sample down, it was a small sample, but they found in that group, they had 50% engagement at 30 days. And as you can see here, fewer opiate overdoses and decreased opiate use. So that was, again, honing it down more as instead of straight observational, but would these individuals be interested? And if you gave it to them, would they take it? They also found that when they went to these sites, no one wanted to give out Bupe. I mean, it was like a weirdness from outer space. And then after they did their education, et cetera, that 83.6 unique ED Bupe candidates received Bupe by 50 unique ED providers. So that was quite cool. So other people have published information I think is really helpful, because sometimes people say, oh, they'll just come right back. I don't know what to do with this. So Ross Sullivan in Syracuse published this last April, not this April, but in 21. He's an emergency physician that also started a bridge clinic to decrease ED visits. And he reported on 269 patients and 654 EDs in 6 months prior to referral. So they had, almost each of them had at least two plus more visits. And then after they had the referral, they only had 381 ED visits. So there was a decrease of 42% after they had that referral than pre. And that 46% of the buprenorphine treatment adherence at 2 years. So if they started Bupe and they went to treatment, they had adherence at 2 years of over half, which is really incredible. So this can work, and it can work to reduce. People say, oh, I don't want all these people coming to my ED. Well, they already are in your ED, right? How about you try to treat them and save their lives and have a potential for them not to have to keep coming back. I used to say that really repetitively. Actually, with COVID, I'm sure they are coming back, but they're coming back with, like everyone else, which is general treatment of any medical disease. And then I talked a little bit about this. If anybody needed extra motivation, the our ASAP, American College of Emergency Physicians, again, Dr. Hawk was the first author in this. We wrote these consensus recommendations on the treatment of OUD and the ED. And so we came right out there and said, this is what we expect of you to do. In addition to that, if you need any more motivation, then this is the Legal Action Center, which is a marvelous group of nonprofits, a group that actually wrote this huge paper, and you can find it there. And they said that if we don't offer this, that we're in violation of EMTALA, which is the Emergency Medical Treatment and Labor Act. This is something that we've had for many years, which makes, and it's the right thing to do, obviously, but when I was a resident, you could be potentially shot outside of a hospital in the South, and you would not be taken to that hospital. You would be taken across town because you didn't have insurance. And that was unconscionable. So the EMTALA came out, and we get huge fines if we do not do screening exams or treat people, or you try to give someone to another hospital because of their lack of insurance or underinsurance. So every ED is very, very aware of this and how they transfer patients inter-ED wise. And that's a huge deal. In addition to that, we also in violation of the Americans with Disability Act, the Rehabilitation Act, and the Civil Rights Act. So this, when you fail to adopt evidence-based practice, it results in patients' harm. And you do the best you can until you know better. Then when you know better, you do better. So some of the limitations is, people keep talking about is, can I treat if I don't have an X waiver? And anyone can always treat withdrawal at any time. You could not write a prescription previously unless you had the 8 hours of training. You had to keep coming back to the ED for 3 days at least to do this. Then in April of 21, HHS released new practice guidelines, which expanded access. And what this did was it said, well, you can just query SAMHSA and say that you agree not to have more than 30 patients a month, which no ED physician would have on their pallet. And you just have to write in and say, yes, I'll do this, and give them your DEA number, and they send back something. Then you write that into the DEA and you get an X waiver. You do not have to do the 8 hours of training. And that's much more reasonable. We've gotten a lot of people to do it, but you can still see it's like huge barriers. So new things keep coming out of trying to make this easier, but really it's a pain in the neck. But what we really need is this mainstream addiction treatment act. And because buprenorphine, when we were allowed to treat withdrawal in 2002, was an act of Congress, it needs an act of Congress to remove it. So I'm really excited to say that last Thursday, the House passed the MAT Act, which X's the X waiver. It is now part of a large mental health package. It went to the Senate. It is thought to be able to pass there easily when they finally take it up. And then the president has really come out and said he would be happy to sign it. So I'm hoping that within a very short period of time, maybe after summer break or whatever, this will happen, and we will not have to worry ever about this crazy X waiver. It does not mean that people don't need training to do this, but as emergency physicians, we give out more medicines than you could possibly imagine in every aspect of patient care. It's often, many of them are new, and many of them are very difficult medications, and we could really hurt somebody by them. But we look them up at the second, and then we do it because we're out of meds half the time. So this is not like this. This does need some training, and just like any other thing that's new, we can teach the pharmacists how to help. We have people on call who could help, and we would expect that to happen. There was, in people asked about what was the incentive for training. This could be different by state for those groups. Like in my emergency department, we required everyone to be X waiver. There was no incentive. You were just required to work. You had to do it. I can tell you that at another great place in Camden, Cooper, which was also one of the wonderful places that started this shortly after our paper came out with Rachel Herrick, all of their attendings were required to get X waivers. They were not given any special money or anything. However, during the temporal changes, there were some places, I don't know if it was Baltimore and Cincinnati, I believe, where the state sometimes paid people or residents to get waivers. And I don't know how many of them did that, but we ran huge courses during this period of time, free courses. ASAP ran them. SAM, our academic thing, Kate and I ran millions of them. We would do them anytime anybody wanted us through SAMHSA. And we did get to have many people waivered by doing that. We did half and half courses. So we ran all of that at the same time. So I'd say the vast majority just did the training, but I'm sure there were people who took advantage of some of these states, and I don't know how much they did. This is the SAMHSA waiver right now, where you can just go in, fill out the page, say that you are going to not have more than 30 patients. So if you're not an addiction specialist, you can do this and they will get back to you. Unfortunately, this takes time, and it's like ridiculous that people have to do this. Again, it's very stigmatizing. An emergency physician can give out thousands of other opioids and can't get this out. It seems like just insanity. This is what we learned from patients, actually. And I actually attended all those focus groups myself, as well as Dr. Hawk. I really enjoy talking with the patients, because you always want to learn something that you don't know. And they were very agreeable in thinking that they really wanted low access barriers to treatment. They would go to the ED, but they did feel that the ED staff didn't understand addiction or perceive it as a disease. They felt like we often minimized their history. Just as soon as they learned that they had a history of addiction, they weren't taking them seriously. They didn't take their pain seriously if they came in. And they had noticed, though, some recent changes as we did this along the course. Some people had told us that things seemed like they were getting a little bit better than they were before, but it was more rare that they had a positive experience with a clinician in the ED. when they didn't. And really, this is all around stigma. And so we have tried to do trainings and just broach the subject of this is what it is. We've tried to get the champions to go out there, and the champions at each site where people really respected them. And if they could normalize this during the course of the visit, it would be better. And I think this is getting better. It's not great, but it's better. As we know, that language does mean something, and we should be changing our language. And even I think that NIDA is going to change the name of their institute very shortly. So people are hearing this, and these are the words on the left that we try to avoid, and we use the others on the right instead. So we call them, we say to someone that they have an opioid use disorder. We don't call them addicts. We don't call people with diabetes, look over that diabetic over there. And we try to talk about disease instead of a problem. We try to talk about negative and positive urines, not clean and dirty. Again, we don't call someone with sugar in their urine as having a dirty urine. It is treatment that we're offering, not replacement. And we often have to go over with both patients and with doctors, what does it mean to have a diagnosis of opiate use disorder? So if you go through those diagnoses, the questions based on the DSM-5, you realize that all of those are based on not just craving and withdrawal, but they're based on consequences and doing it no matter what behaviors. And that if someone is on medication, they're not doing that. They're not selling their parents' jewelry. They're not going out on the street and doing all kinds of risky behaviors. That they are getting a prescription from a healthcare provider, and that prescription is lasting over a certain amount of days. And if they need more, whatever, they see that doctor, that clinician, and they're doing it under their care. And so they would not meet those criteria if you looked at it again. And so this is treatment. We expect that sometimes there is return to use, in case we don't like to say relapse, but there is return to use. And we don't like to continually talk about failures, but more about treatment attempts. And I don't know, every time I was just in ED this week on Monday, and I had somebody who'd been there like 4 times with hyperglycemia. I don't go over and yell at the person or want to know what why they're doing here and stay out of the ED. I treat them. I did the same thing, ask them, what was going on and what did they think we could do for them, and tried to meet them. This was an individual who just didn't want to take medications and she really needed to. So we had a conversation. I used the same skills of the BNI that I would with medication for her diabetes. And she agreed to let me start her on metformin, and we did that. And I will follow up on her because I put her in the nurse follow-up lot. So you can use this for anything. And, we wouldn't be so harsh with her that people would have been harsh if someone had been back 4 times with a drug use problem. So anyway, we figured out how we translate all this into practice, and I'm willing to share anything that you want with us, but how do we do it? It really is around treatment and linkage. And so our pathways really involve, again, identifying the person, assessing if they have an opioid use disorder, using the cows, as primitive as it may be, for withdrawal. We always do pregnancy tests because people want to know if they're pregnant or not. It does not change our treatment, but in many places, people can jump the line if they are pregnant and people want to know about it. We have an algorithm I can share with you, and then we go ahead and treat them either in the ED or again on their own, and then we discharge them with instructions in both in overdose prevention if for any reason, and in our institution we hand them the Narcan. And you can use, someone asked me about Suboxone. Yes, you can. There is a theoretical question of whether or not you can use the naloxone with the buprenorphine pregnancy. Everybody who does this in real life does go ahead and use that. They're just very careful with telling them how to use it. Theoretically, people said you'd need to give something more like Subutex, the buprenorphine without, but no one in real practice does that. The only time I tried to use Subutex or buprenorphine free is when I'm using lots of high dose, and it's more difficult to sometimes absorb them all. This is our ED initiated protocol. It's very similar to other protocols, and we vary it all the time. But so if they're less than 7, we give, or 0 to 7, we give them unobserved induction at home. And if they are greater than that, we start their dosing. And quite truthfully, this is how we used to do it with 4 and then 8. Quite truthfully, now I just give 8 most of the time. And I'm willing to give a lot more if they don't get better or if their symptoms get a little worse. And I give them as much medication. Here you can see we give them 16 milligrams per day. No matter how much I give them in the ED, I always send them home with 16 milligrams once a day. I give it to them for as long as I need to. I'm lucky in my place that in most places I can give less than 7 days, but I wouldn't give less than 5 ever. And then I will give them more if they're going to one of our places. It's a little harder to get it to, but I don't care how many days I have to give it. If I had to give 10, if I had to give 2 weeks, I don't care what it was. During COVID, there was a lot of issues. I'd give them as much as I need to give them to make sure that they could come back. They would have enough. And so this is California Bridge. They have a very similar thing, and now they're upgrading this. They probably now are giving much more bupe than we did. This is our guidelines for it on your own. And we talk to them about making sure that they are really in withdrawal. And when they really think they're in withdrawal, we say wait a little bit longer. And then we have them take 1 and wait unless they need to take it. If it made them feel really worse, we take more. So now we know with fentanyl, people might need a little bit more so they can step this up. Kind of go over it and said, we're giving you enough. We think you'll need 12 the first day and 16. But if you feel worse, you can take another one. It's not going to hurt you. I'm really excited to say that Embed, which was one of our clinician decision support that we did as part of another trial, a UGH3 trial with NIDA, just got published yesterday. We put the, it's in BMJ, and I put that reference for you there on the bottom. This was like over more than 4 or 5 years study where we actually embedded buprenorphine into the Epic and Cerner, and we divided 5 health systems and lots of EDs into those who were going to get interventions and those that did not. And these care pathways went into whether or not you had a waiver or not. And it could give you any information you wanted there on the right. You could diagnose OED. It would tell you how to do that. It would tell you how to do the scale. It would tell you how to motivate people with our techniques if you wanted it. But if you didn't want it, you could just go right through and order. And out popped everything, including referral sites to where they would go, and their note was written for them, and it was all really great. And I'm happy to say that we have apps that an app that has been developed, and you can download this Bupe Initiation, and everything is really on there. So you could just have it on your phone. And what pops up here is just this screen that says opiate use disorder, opiate withdrawal, and are they ready? And you could on your own just go through here and say, yes, they have this, where you think their withdrawal is, and yeah, they're ready, so whatever. You don't need to do any more. And you just tells you then to go ahead and prescribe, and it tells you what to prescribe. If you don't know these things, you can press on like opiate use disorder assessment, and it will again give you the questions and score it for you to get moderate or more opiate use disorder. And if you don't know the scale, you can go in on the scale and you can fill that out on your phone as you're with the patient if you want, and that will tell you what to do. This is all now in Epic, and today we did the rollout of Epic with all the Epic sites. We had hundreds and hundreds of people online, and it is now in the May update. So it's really, really, truly just embedded as a care pathway, and it's very cool. So writes the note for you, does everything that you want with minimal changes that your site has to do by putting in where you're going to refer people. So that is there. This is a little bigger. So if you can see it, if you couldn't see it before, this is what it looks like on your phone. And we have lots of things on the NIDA website. Just going to tell you that on the right, there are all these cases of motivating patients. And most of them are like only 5 minutes, except for the adolescent case, which is much longer. But in the other cases, it goes over if someone's ready, if they're seeking treatment, they're not ready, if you're just going to do harm reduction, how you do that. And it's a very nice thing to see on the initiation, as well as in EPIC. There is a whole area where if the patient is not ready, it will give you 3 or 4 different sentences of how you can motivate that person to perhaps seek treatment. It also, by the way, in EPIC writes the whole notes through you so that the physician will have this note that says the patient met criteria, the patient has untreated OUD. They declined treatment, but we've given them overdose information. We've given them naloxone, whether it's prescription, depending on your site, and we've given them a referral so that it really meets all that criteria. If in fact something does happen to that patient, you would be actually fine that you had tried all of that, it didn't work. So lastly, I want to talk about innovative treatments that we're doing now. So one of this is a paper we wrote on high dose buprenorphine induction. So Dr. Herring, who is out in Oakland, California, actually had read my paper and said, I'm going to do this immediately. Dr. Herring is an incredible human. He's boarded in emergency medicine, pain, and addiction. He's quite a clinician. And so he had all of these cases that he had done. So we got some money from one of our CTN, that first project that we were doing. And we set up a study, a retrospective case review. It was really done as well as you can do a retrospective case review of the entire year of 2018. There were 391 unique patients and 579 encounters when they came in and received some type of bup. There were no cases of respiratory depression or sedation, and there were only 5 cases of precipitated withdrawal that were not related to the dose. So we concluded that it was safe and well tolerated in this population. And this just shows you some more data from that. And on the left, you can see the respiratory rate really did not change from 2 to 6 all the way up to 28 or greater. There are only, some in that. So we put every grouped them in. We considered high dose anything over 12 because that is really the FDA's amount that people should supposedly have the first day, an old amount. And so we thought that anything over 12 would be considered high dose. And then we separated it out because this is how people actually get it, 16, 18, 24, or more than 28. And then you can see that there was really no change in respiratory oxygen saturation either in these cases. When you look at them very specifically, you can see that the majority of people got the high dose. And of those people who stayed longer in the ED, they were at the low end of the categories here, like in the 2 to 6. And I think in retrospect, when we look back at these patients, there were people that they were worried about. They could be older, they could have COPD, et cetera. And so, or they could have had something else. Perhaps they had an infection and they were concerned about where the cows really lied and they gave them smaller dosing. But if they really thought the patient would do well, they gave high doses right away. So the people that were in the ED longer were those people that were given the small amounts. And I suspect that's probably due because they were concerned about them. They were also more likely often to be hospitalized. So it really didn't matter where you were here, than if you got this or this, or if you got 3 in here and you see 4 up here and 8 here, it didn't really make much sense. And also return to the ED and the time when they return to the ED. Majority of their individuals in this institution are homeless, so they are a very, very vulnerable population. And the good thing that happened was that everyone was doing it. So this wasn't 1 or 2 individuals. These were 54 unique providers had given out doses, all of their APPs, and 29, which was 88% of the physicians on staff, had administered high-dose buprenorphine at least once. So this wasn't just, Dr. Herring giving it out, or, 2 or 3 people. It was everybody. And most of these individuals went to the non-acute areas that were run by the APPs. And so a vast amount of them were given by APPs versus MDs. So it was safe and effective. Another thing we're doing right now that we're testing in ED Innovation, which is CTN 0099, we are testing a 7-day injectable, which is CAM 2038, which is still under IND, so it is not to market yet. So that on the left-hand side here, it tells you what the plasma concentrations over time. And this little gray line here is sublingual. So you can see you get this massive rise initially, and then it really decreases over 24 hours. Whereas if you take the injectable starts to rise. It gets at 4 hours around 2 nanograms per milliliter, progressively rises, and then it lasts for 7 days. So it goes over. So, and it is a very little injection. It's a lot like Lovenox in the same kind of injectable thing. And it can be given anywhere except to start in the arms. It causes more pain in the arms and redness. So we give it in the abdomen, the thigh, or in the upper gluteal area. I personally always give it in the upper gluteal area. I think it's easier. So this study that we're doing compares the effectiveness of XR-Bup and sublingual Bup in approximately 2,000 patients with untreated OUD and the ED. And the primary outcome is just getting to this addiction treatment. So it is really, informal is addiction treatment, like not, again, anything that is required by ASAM that they get to there. And really, we're hoping for ongoing OUD treatment. So in this case, we have now enrolled 990, actually today, 996, I believe. Might be 7 as we speak. We started in 27 sites. You can see them all over the US. Dr. Vilene and I are the lead investigators on that, but it's a massive amount of team that is doing this. This is just our core investigators and our partners at NIDA. So these core investigators are all over the place, whether at Penn or Dr. Herring out in the West Coast, or 2 of them in New York. And we're very excited. As I said, we've enrolled all these people. And what is really interesting is that we have only had 10. And now, as I said, we're almost approaching 1,000 now. We'll get there, I think, by tomorrow. We have only had 10 cases of precipitated withdrawal. 4 were in the XR group and 6 were in the sublingual group. So there seems to be a lot of conversation around precipitated withdrawal, but we are just not seeing it. So here they are. All these sites that are currently enrolling are in the blue. We've lost some sites because they were unable to enroll patients from a variety of different reasons. So it's an expensive trial. We are at 22 sites in 21 institutions all over the place. And these are the locations of the precipitated withdrawal. As I said, the 6 sublinguals, you can see the red flags, and then the XR-Bup and the 4 are in the blue. So that's it. Precipitated withdrawal, as we describe it, is usually within 1 hour, although it can be, especially with XR-Bup, it can be longer than an hour. This was what it was originally written before XR-Bup. And it is rapidity of really worsening symptoms. And it's really easy to see when people rapidly deteriorate and skyrocket. All of our cases of precipitated withdrawal, though, every time medication is given, the CAL score is entered, and then we have our experts, which are Dr. Walsh and Dr. Loftwell from Kentucky, and they review everything and have to agree that it is precipitated withdrawal or not. And this is something I took off of the web, but this is, to me, what happens when precipitated withdrawal occurs. the clinician really is very distressed and, oh my God, now what do I do? And the best thing I can tell them is go ahead and call for help because we will get you through it. We do know how to treat it very rapidly. And of those 10 patients, they all went home. We just give more bupe. We've given the mono product, but now lately we've been doing, when people are giving mono product for a variety of reasons outside the study, people are using it, using the Suboxone too, because some people will do better with all the strips and, multiple strips in the mouth than they will do with pills trying to dissolve in their mouth. So I really think it doesn't matter as long as they're capable of not swallowing it. And then we can give some ancillary medicine, particularly people may get nauseous, although in Dr. Herring's study of all those people, we had very, very few people, a few percent who complained of nausea or got medications for nausea because we queried the charts. So that was not very much, but we can give a variety of different medications if we need it. We found that fluids often work hard. People are often dehydrated. We give a touch of lorazepam. What I mean by that is 2 milligrams. If they need it to, basically they got to rest. If they have a home to go to, it's really nice for them to curl up in their home. But we find that that's not really the case in many of our patients. So we try to find an area where they can be in a quiet place and give them lots of medicine of buprenorphine and watch them. And we've been very successful and all these patients went home. Yeah, so I will talk about, let me finish this about low dosing because I'm really not a fan of low dosing. And if someone could give me any data to show that it works, I'd be happy to see it, but I don't see it. What we do see, and Dr. Herring sees a lot, are people starting low dose. And by the time they get to day 3 or 4 on the outpatient, they're back in the ED withdrawing. And then he treats them. So I'm not a fan of it. I think that when you do give low dosing, you are committing individuals to go out and use illicit drugs. If you were bringing someone in the hospital and you're saying, oh, they're hospitalized for some reason, I'm going to give them a full agonist, pharmaceutical full agonist, and I'm going to start them on low dose. You could do that. There's nothing wrong with that. It certainly works if you're transitioning methadone patients to buprenorphine. I'm talking about discharging people from a hospital or a clinic with low dose. Of course, I always go where people are. And if they say, I'm only going to do this, then you do that. But I would tell you, we don't have any problem doing this. It could be that we are enrolling people in studies. So maybe there is some bias, but even if I'm 10% off or 20% off or 100% off, I really don't have that many patients. And we are treating them really fast. Because if someone starts to not feel better or they look a little off, we just give them more bupe. So it's possible that we have averted many cases that maybe you wouldn't have in the community if you just said, oh, start this and then make them wait for 4 hours. We just give them the dosing, the 8 if they're getting sublingual. If they are in moderate withdrawal, they get 8. If they don't look good, they can get 8 more. So, and clearly if they really didn't look good, they would get a lot more. And we'd watch them, but we do check. So if they look like they really have escalated, they would still be considered precipitated withdrawal. We would treat it. This is what we see too. So what I wanted, these are urines all over. This was our first 475 patients, but it's very similar now with more patients. It's exactly the same, is that we're seeing lots of fentanyl. So you can see up there that there's around 76% of people that have fentanyl in their urine. So it's either fentanyl plus another drug or fentanyl alone. Fentanyl and no other opiate is around 28% overall. You can see it's more so in the East Coast than the West. We split these East and West up by the Mississippi River because other investigators have done that. So that's how that's what means East and West here. So you'll actually see there's more meth on the West Coast, there's more cocaine on the East Coast. But the point of showing you this is just that fentanyl is rampant and it gets more and more rampant everywhere. So it isn't that these sites are seeing more or less fentanyl, they're all seeing fentanyl. So I'll talk more about that. I'm happy to, but in conclusion, we know that the extent of the problem, we know that treatment works. We know that the ED offers this option of 24/7, 365 care. The consequences of inaction are horrific. The evidence is in. We learned how to break down barriers and increase chances of success. And we are investigating things like strategies, dosing, formulations, and surveillance techniques. But overall, this is really, at the end of the day, offering buprenorphine is not a choice, and we're hoping that everyone would do it. And we don't really want to stop until everybody has something like this, that California Bridge has this. If you need help, this is right out in triage with pain pills or heroin, because that's what it was initially out there. And people still think they're taking heroin, even though they're not. We want to help you get off opiates and start on buprenorphine. Ask here for more information. So we have lots of websites that we can share with you here, and lots of papers and everything that goes on there. And I think that is pretty much it. And I'm going to start answering some more questions. That's okay. And I'll get out of, just see. I'm going to stop sharing in a minute just so I can, if there are any, I don't know if we see faces. I guess we don't. We don't see faces. But anyway, I had a couple of other questions, so I'm going to, what is the reason naloxone? Oh, it's not filled because people, one, need insurance to do it. They need money to go and get it. Depends on state, especially if you're not in a Medicaid expansion state, and who actually fills any scripts all the time, right? So these are individuals with opioid use disorder. And transportation can be a really big deal. Money can be a big deal. There are just many, what we are seeing now in the differences in our first study here in New Haven, for example, that we were enrolling people, we published in 2015, so maybe like 2009, 2010. Those individuals were, maybe we had 15 or 20% that were vulnerable and didn't have housing. Now we are seeing in 69, in those 4 sites, that there were over 60% of our patients had unstable housing, currently had unstable housing. And I don't have the data yet for 99, but I suspect it's even worse. So, people don't get things filled. That's why it's so complicated. That's why an injection might be so great. And if you talk with Dr. Herring, when he sees them in clinic, he immediately injects them with Sublocade. So they come there, even if it's the next day, they did well in that, their induction, great, fine, here you go. Here's the Sublocade. And patients really like that. Another interesting tidbit he had, that of all the people he ever put in precipitated withdrawal, or anybody in his system, they are much more likely to show up at treatment with him. So 85% of the people that say that got precipitated withdrawal, like you can look in their charts, show up. He said it's much less, it's more like 50% of people overall that you start on bup. So for whatever reason, they may have had a rocky course, they're okay with it. And I can give you an anecdote with us. We had a patient who was in precipitated withdrawal. I'm actually not quite clear if I did it or they came in a precipitated withdrawal, but we treated them. And they stayed for a fair amount, because they came in like in the late evening. They stayed overnight. They got all the bup, they got other things. And by morning, they were sitting up having breakfast when I came in to see them. And then we were in this, we called them at 7 days, because we were always asking them, did you get to treatment, or, how are you doing? And they gave us this great anecdote that they had a friend that they live with who wouldn't take bup because they were concerned that they would go into precipitated withdrawal. So he gave them our protocol. He said, oh, they just gave me a whole bunch of bup. So why don't you, they have their own bup on the street, just take a whole bunch of bup. So he said he himself helped give a high dose buprenorphine induction to his friend, and that friend did well and was on bup. So I think it's mostly us that are telling people and getting anxious that people are going to get into this, have this phenomenon, and people don't want it. There is no question that we are seeing rocky courses. That's no question. I never saw any of this. I enrolled all of those patients in the first trial myself. I never had any precipitated withdrawal. I've done hundreds and hundreds and hundreds of inductions. And lately I have seen it. I've seen people come in with it. I did put someone in precipitated withdrawal in another study where we were giving out XR bupe with people who weren't withdrawing at all. So I've had my share of that now in terms of people coming in and having had put themselves in. And I just treated and we're able to do it and people are okay. And this wasn't a talk about precipitated withdrawal, but then we give ketamine. So in all else fails, we give 20 milligrams of ketamine. We give it IV over a few minutes and people do really well and are very happy afterwards and go home. I'm reading some of these so I can think. There's a question about a lack of standard of screening and intervention, OUD evidence, and how your team did this in your ED. Well, I think quite truthfully, what it comes down to is leadership, and the leadership just has to say we're doing it. Is there any other disease where we actually know how to treat someone and we just choose not to do it? So I'm kind of over this. I'm hoping that the LAC will be aggressive in suing people who don't do it. All right. And so if my family member died because you didn't feel like offering it, you had obviously some mental problem that you didn't want to give it out, and I would sue you. So I'm hoping that people will realize it's not a choice. You know, what if I decide that I don't feel like treating an ST elevation MI? I'm really sorry. I don't really believe in that. I think you're wasting healthcare dollars and I don't believe you. And I'm going to let you go and I'm not going to do that. Or God forbid we didn't give someone tetanus. And quite truthfully, I've never seen a case of tetanus in 30 years of practice. But I don't think there's anyone that leaves an ED without a tetanus shot, or if they've never had primary immunization, that they don't get it. So I think that we're well beyond this. And I'm happy to say, because ACEP came so clearly out by saying this is required, this is a consensus statement, this is what we expect. If someone doesn't do it, then that would be seen as a derelict of duty. So I can only hope that that will be the case. A lot of patients don't want treatment, and that's their right. I still would try to motivate them and ask them what would need to happen for them to want to have treatment. What could I do to make that happen? I, as a doctor, wish they took the treatment, but if they don't want it, then I would offer them harm reduction and say, come back at any time. And I would just write a note that we had a E&I conversation, they declined treatment at that moment, here's the referral. And Epic will do all that for you if you know, with a couple of clicks now. So I'm trying to read this. So the cows can be high because of no
AC. So sometimes it's hard to tell what the cows is. So is the addiction specialist.
Okay. No, we've trained actually everyone to do the cows. The cows is a very imperfect score. So the way that cows will really hurt you is if the person has an infection. So if the person has an infection, you can see that all those things will be up. They'll be tachycardic. They can be sweating. They can be red. They could be, if they really have really septic, they can have change in mental status. They can be irritable. There's lots of those reasons. And so one has to always make sure that one is not infected and contributing those symptoms. That's easy by just asking the person when they last used, all right? And so you kind of get an idea of where you should be in that withdrawal cycle. The other really difficult thing is that unfortunately people are drinking a lot of alcohol now. Whereas before people generally had a primary drug and it was unusual, but it's not unusual now for people to have an alcohol use disorder and an opioid disorder. And obviously those treatments are diabolically crazy. So you need to give them the buprenorphine or method of we admit those to the hospital, because then I need to give benzos on top of that. And then that's really unclear. It's unclear how I'm going to differentiate these two withdrawal states. That takes an addiction specialist to help with that. And so we generally admit those people. I have outpatient treated people that have benzos or any other disorder along with the opioid use disorder, any other substance use disorder, but the alcohol use disorder in combination is very, very difficult. So if they have ever withdrawn before, like had real withdrawal, then those people will get admitted for managed withdrawal. And I think we should think about this because these these are clinicians who need to know how to treat this, just like we treat, how do you read an EKG, right? How do you do anything? There's nuances to everything. So we teach them. And also I think it's really nice that people have someone to call. So we have now like 6 addiction boarded people in EM in my ED. So they could call either of us, any of us, and we'll go over with them. But in any other place, they could call an addiction specialist, just like they call cardiologists. They go, I'm not so sure about this EKG. What do you think? If it's the interventionalist, this is the story. Do you think we should open the cath lab? You call somebody and immediately they answer. So that could be the same with an addiction specialist in your system. If you're unclear about something, you could call them. But I certainly do hope they know how to treat this. Okay. So I would be careful about who you call that it'd be an addiction specialist. In emergency medicine, people call a bunch of us. I call other people too that I know if I'm in trouble. They call me and we walk through the cycle. And once somebody has been through one rocky course or one precipitate withdrawal, they're fine. They got it. They know how to deal with it. I don't understand this question. How do we prescribe naloxone with so buprenorphine often comes with naloxone in combination. It is a way to deflect use that is not medical use, so that if you kind of heat it up and try to inject it, you'll get the naloxone and not it. So it's how Suboxone and most of the preparations come with naloxone and Subsol, whatever, they come with that. You can order straight buprenorphine, but many places are discouraged because they don't want to divert it. So somehow that's the way it was prescribed, but it always has it. Most of it has a small amount. 8 milligrams has 2 milligrams of naloxone. It will not be, if they use it the correct way sublingually, it will not be absorbed. Do you have ACC? I don't know exactly what that means, but yeah, so I did go back. The 69 sites, yes, well, remember, it's easy because during the course they had to take the 8 hours. So now everyone is getting waivered ED docs because of the easier way to do it, and their chairs are requiring them to do it. But they're using more bup even than they did during the study. They're using much more. We are part of EQUAL, which is a CMS. CMS requires that hospitals, particularly like rural hospitals, do some endeavors to make things better qualitatively. So there's something called, ASAP has this thing called EQUAL, and you could choose. Many hospitals, over 500 small hospitals, have chosen to do something around buprenorphine. So we do have some evidence from them that they are, they're prescribing opiates, other opiates less, and they are now doing protocols. I'd like it to be better, but there's many of them who are promoting buprenorphine protocols. I would like it, again, to be a little bit stronger than that, and I would like CMS, am advocating for CMS to do something exactly like they did with ST elevation MIs with people with opioid use disorder, that hospitals will be insanely penalized if they don't do it correctly. And with ST elevation MIs, we did for years, people would come in and look at your charts. You had to have special people, you had to present them, you had to always say why something didn't happen, and very lengthy. It was like millions of FTEs for something that we only see 10 or 20 a month. CMS dropped out of that, using that, because everybody does it now. So door to balloon is now, expected. So they stopped out on that. I would like them to take that up for opioid use disorder and really fine massively hospitals where their clinicians are not following evidence-based treatment. So if I could do that, I hope that will happen. And you want more? I got more. Okay, we'll keep talking. Buprenorphine is stocked in almost every pharmacy. I don't know of a pharmacy that does not stock it anymore. They may use a particular type, like it may all be buprenorphine with naloxone in it. I doubt that they would have the Subutex because they might not, but there are pharmacists that have it. Your pharmacy should have it in your hospitals. There should not be a problem. So there is a definite fear of precipitated withdrawal on the street. I can tell you in New York, it's very, very strong. I was just talking with someone there today. Somehow people are saying, oh, I don't want to take that. I think part of what's happening is that people are, there's more buprenorphine on the street. Everyone seems to have their own supply. Like that never happened before. So there's more in the community, and used to be with heroin that people kind of knew when they were going to withdraw. Like they could use very exactly like twice a day. They could have great jobs. They knew exactly when to take their heroin. And they knew if they started to withdraw at a certain amount or at a certain time period after their last dose, they didn't have the heroin, they could go and get a bupe, and that would make things better until the next dosing that they got. This is not true of fentanyl. People are using fentanyl very differently. They're using it constantly over the day. And people are more and more nervous about withdrawal. And I believe that they're most likely starting that bupe in the community before they are in full blown, real withdrawing, like at least somewhere in, I tell people to get to 12, but somewhere in there where you're really withdrawing, like on the street. And if that's not the case, and they take one early, which is what happens when I interview all these patients, they're going to go in pretty much in precipitated withdrawal. We know it has to do with something people have presented to me, ALE. So it's really around the amount that they're taking, and the lipophilic action of fentanyl. It's very lipophilic, and so it's where they're adhering to it and where the receptors are at and the efficacy, and that is really how many receptors are available. So if initially someone's using a lot of fentanyl, those receptors are really taken up. There may not be a lot of receptors available because these receptors are downregulated with lots of fentanyl, and you've got to get those receptors available to take the bupe on it. So it really is that affinity problem, and if they're not in withdrawal, then that fentanyl is on all those receptors. So we have to get those receptors percolated up to get the bupe on it for it to work. So this is kind of hypothetical, but it really does kind of map out to where people are. The further out they are and more in withdrawal, the less likely they will be in precipitated withdrawal. Okay. So yes, it is why people want to do low dose, but low dosing, let me explain to you, low dosing is no different. 2 milligrams of buprenorphine is really quite a lot of buprenorphine. We don't think that it is, but it really is a significant amount. So you are going to, even with 2, could precipitate withdrawal if they had just used fentanyl. And the other thing, if it isn't, and you're starting to recruit some other receptors, you might do well for a few days, and once you get to 8, because they will be using with that. There is no one who can take 2 and not use some other agonist, because they will be withdrawing like hell. So they're going to use other agonists on it, and then depending when they get to that stage, I'm going to use more, they will go into precipitated withdrawal. So it makes no physiologic sense unless you are in a controlled environment, and I am going to give you some agonist, and I'm going to give you 2, and we're going to play this game where I'm going to try and get these receptors more and more up there to be used and less desensitized, and then I will get you on a full dose. I can do that. We do that in the hospital, but you can't do it as an outpatient. And then doing it as an outpatient, either they're going to get more confused amongst themselves of how much to use, and they're going to precipitate, or they're going to die because they're using a non-pharmaceutical medications. And we unfortunately are not allowed to give them a morphine equivalent. So that's why anatomic, just from a
you're on this subject.
biochemical, So last use of fentanyl, I think this is an interesting thing. We don't know this for sure, but those of us who are on these calls every day, Dr. Herring, Dr. Jean Maureen Perrone, we're on every week calls, Dr. Ethan Callan and Dr. Hawk and I, we believe it's at least 6 hours. So I'd like to get people into in at least 6 hours and assess where they're withdrawing. And if they're not really withdrawing, even that, I'd wait longer. But I don't think that it can be less than that. Now, we can, when you think about the science, if, for example, someone had a reversal with Narcan reversal, and you blew everything off of a receptor and put them in full-blown withdrawal, you have a very brief time there where you could load bupe up. All right, so it's possible within that hour or half an hour, and people have done that on the streets, EMS, where you know they're not taking methadone, they swear they're not taking, although everybody now seems to be taking it because they don't even know they're taking it. But if they swear they're not taking methadone and they're not pregnant, if you could try this, you could, if they had a naltrexone, a naloxone reversal in the field, and they were willing to take the bupe, and you give them high dose bupe right then, they'll do fine. And there are places in California and again, Camden, who are doing this with pre-hospital providers. They call in for a direct, a physician is on the line. They are trained, specially trained. The physician talks to them and they say, okay, go ahead, give them 24 bupe. So it does work, but you have to know where you are. Like, these people are probably not taking methadone. That so you need to know your area pretty well, and it can work, but it's not going to work 2 hours or 3 hours later when they get to the ED, because then naloxone is worn off, the receptors are back, you're going to have a problem. So then we want them to be in pretty much withdrawal before we would start. Okay.
It looks like we're at time. Thank you, Dr. D'Onofrio, so much for this wonderful presentation. And we apologize for the questions that weren't answered, but thank you so much, Dr. D'Onofrio, for answering the ones that we had.